Since the Philippine General Hospital is a COVID-19 referral center, this has had a significant impact on the caseload of our fellows. Our fellows in training were considered part of the team of doctors managing COVID-19 patients in the ICU and in the wards. One of them even contracted COVID, fortunately only mildly symptomatic. For the first 8 months of the pandemic, we were seeing more COVID than non COVID cases, since there were hemodialysis centers that refused to accept COVID 19 positive patients. PGH accepted COVID 19 positive patients who were on maintenance hemodialysis. We even had one ward solely designated for patients needing dialysis. Because of a delayed clearance of the virus or virus particles from these patients, it took some time for RT-PCR swab tests to become negative, and these patients would spend more than 2 to 4 weeks in the PGH wards. Kidney transplants and other elective surgeries were put on hold. Less renal biopsies could be performed. On the plus side, our renal fellows have been able to conduct some COVID related researches. Some of them have even been published. And in addition, fellows in training also witnessed the resourcefulness and adaptability of the renal unit to nurse shortages due to quarantine issues and learned how to prioritize patients for renal replacement therapy. As the number of COVID-19 cases has diminished, more non-COVID patients are now being admitted. Our inpatient census is catching up with pre-COVID era numbers. However, face-to-face outpatient consults are still limited, and teleconsults are encouraged for outpatients who do not need urgent or emergent care. Section conferences or division conferences resumed in June 2020 and now are conducted online by the Zoom platform instead of face-to-face. Except for the Zoom format, the types of conferences, M&M, topic conference, journal club, transplant conference remain the same. Fortunately, we have been invited to participate in other inter-hospital conferences, such as the transplant webinar series of the National Kidney and Transplant Institute. Our inpatient census is catching up with the pre-COVID census. With the increase in surgical procedures, we are now seeing the usual preoperative and postoperative renal complications of surgical procedures. Examinations are still conducted on a regular basis, this time online using Google Forms. Outside rotations have resumed.
In our institution, it has really affected, no? So the cases has decreased, the ROPD, because for like last year, everything was closed, so our fellows would have limited exposure to the OPD. So we have to innovate. Like we end up like since when we started restart the clinic, we especially for transplant that they cannot rotate in NKTI. So what we do is I group my patients and the TOs patients for post-transplant NGN and bring the fellow to be with us. So they get to see the follow-up and everything. The other innovation that we have to do is for some cases that it's really that is we like we have a meeting and I pose as a patient with a complaint. Then they'll start asking questions about the history. So I would give the history and they would try to interpret rather than just giving an oral, because an oral, they would just formulate here. We should train them how to ask history and everything, the pertinent to nephrology cases. So that's what I do. Either me or the TO or the other consultants in our institution will do that aside from the oral exam. So I think that's the one, but it's definitely had it affected, but it should not stop us from training. So those deficiency, we have to innovate. So doing a combination of like so-called like preceptorship, because they cannot get it. So if we have cases, so like also if there's a case, that they have not seen it, everybody will be called to join, even if they're not the in charge, nephrology in charge. So we have to make use and give everything and then learn from one case. It's like say transplant. They have one transplant, but they have to know from review from the workup that that one we will just make it as a case, a presentation. We discuss it, then how the actual transplant, and post-operatively, if it's follow up, the patients would follow up, then they would have to come to our clinic, or if it's a virtual, then they just tag along with me to have a virtual clinic with a patient. So we have to innovate.
First of all, because of the COVID pandemic, the number of patients that everybody saw were much, much less than before. And that would include OPD patients from an average of 12 patients per schedule of the fellows. It went down to about 4 to 5. That's actually being hopeful for the day, because when we started, there was no OPD at all. We had to cancel everything. But once it started, it slowly went, the census started to go up, and now it averages about 4 to 5 per fellow per day. That's the first one. The second one that really showed a big impact on was on the KT patients. And we had nothing for how many months? And I think we don't even have had any even social service kidney transplant patient for 2020. So that we allowed our second year fellows to go to Global City, for St. Luke's Medical City Global, to observe whatever that they had for kidney transplant. So that's the second one. Of course, the outside rotation was affected also. We had augmented our kidney transplant exposure and the PD exposure by asking our fellows to go to National Kidney Transplant Institute. However, since this was not allowed during the COVID pandemic, so they just stayed in our institution. So that was greatly affected. Um, um, the St. Luke's, or I should say NKT, actually, um, one of their what we call this requirement was for the mother institution like St. Luke's Medical Center should shoulder the health expenditure of the fellows if ever they would get sick. Okay, so one of our nephrology consultants actually said they became experts in COVID patients, but not the case that they should actually be an expert on. On the lectures, it was very good because it became virtual, so that we had more attendance with the consultants. However, this would still be difficult because interacting face to face actually is so different than just watching everybody on virtual on an online platform. And one thing good about it also was we were able to invite other institutions to join our conferences. Like with the kidney transplant patient, we had a conference shared with the global fellows, and for the pathology conference, we had invited other fellows also from other institutions like East Avenue and Global, also St. Luke's Global. And the research was not really much affected by the pandemic. They still continue to do their research, and hopefully they will be finishing all the researches by the end of their training. And one thing good, they did a lot of self-studying because of the limitation in exposure to our consultants, and they were allowed to attend the most number of webinar I think meetings in the history of a fellowship training for 2020 actually. So, and they were able to attend international conferences because of the online platforms.
The crisis of COVID-19 has brought major challenges to fellowship training. Many aspects like clinical rotations, didactic activities, evaluation, and social interaction have been impacted. A drastic loss is bedside teaching, which is integral to the art of medicine. There is little to none of it these days.
Before the pandemic hit us, actually in 2018, the University of the Philippines College of Medicine has started introducing blended learning as a new method of instruction in the basic sciences, particularly kidney physiology. And even in the clinics of the Philippine General Hospital, we started using it with our residents and fellows. It combines online as well as face to face, but more of the former. It was a difficult start then. There was much resistance, especially from our senior colleagues, who will always say that leave this teaching style to the young techie ones. There will always be this comment of the internet is poor, we don't have gadgets, the institution is not wired, and so forth and so on. It was really difficult. Then, bam! COVID 19 struck us so fast that everyone was caught by surprise. The need for physical distancing, which is the antithesis of medical education, is really paramount. Blended learning has been catapulted to unprecedented heights overnight. We learned to adapt. Zoom and Viber have become household names. Virtual teaching was fast forwarded. Prematurely, I would like to think not, because our institution has foreseen it and was prepared. Now almost everyone has become techie. Even our most senior professors can manipulate Zoom, at least the basics, can share screen, can have virtual backgrounds, can even be an examiner for an online OSOE or OSCE. The world became smaller in the sense that we can communicate and share with anyone, anywhere, with our Zoom meetings, webinars, and web shops. On the downside, we still need that human touch, that human face, that human voice, that human bedside teaching through rounding. No technology can actually replace them. The pandemic didn't only take millions of lives, but also might dehumanize us and the future generation as a consequence. COVID 19 separated us, but technology connected us. Moving us apart actually made us closer.
First, when we encountered the coronavirus crisis, there was an issue on trying to segregate people. It's important to segregate those who are going to the possibly infected wards as compared to those who are going to the safe wards. So we started off by immediately dividing our training fellows as well as the consultants. No? Those who would be assigned to what we call COVID risk areas, such as the emergency room and areas where there are COVID wards. We wanted to make sure that they were segregated in terms of even where the rest, there is no contact from what we had fellows that were assigned to the safe wards. Okay. Um, then we also made sure that when the rotation ended, we had a few days that they were sort of quarantined before they actually, and a COVID test can be done before they actually went to the clean wards. Okay, so I think the the main problem was trying to make sure that their vertical training, meaning what we expected them to go through the whole 2 years of training program, will not be skewed just to be on the COVID and infectious type of renal disease. So we had to um, change the make sure that the conferences were going on topics that were not only COVID but as well as important topics, including glomerulonephritis and all that. The OPD had to be changed as well. We were one of the earliest, after a few months that it was no OPD. We adapted to an OPD that would be telemedicine, and our fellows are doing that right now. The main that was affected really in terms of training was transplantation, since early on there was really no transplant going on, and so exposure to our fellows were limited. Um, Once the transplant started um, going on, we tried to just say that it will not be that one fellow assigned for the whole month for transplantation, but um, making sure that maybe two or three will be exposed to a certain transplant instead of one. So it will be shared rather than just because of limited numbers. So it's not been easy, and we don't know the end result whether we're able to accomplish. Um, but we've been trying to diversify either through telemedicine or changing our program so that making sure that the expectation for the whole 2 years will be somehow be maintained, including procedures, biopsy, both living and both uh, transplant and donor biopsies and transplant and regular biopsies were done by our fellows. So we'll see. This was, of course, with the help of my very good training officer. Um, we did had a lot of discussion with this Dr. Russell Villanueva.